Thank you so much for the kind introduction. Again, good morning to everyone. My name is Dr. Arnil, and today it's a drier topic from me. I'm not talking about cancer management per se, but it's something that's very important that we all need to be aware of. So my talk today is addressing disparities in cancer care and role of multidisciplinary team meetings in Malaysia. Now, okay, I have now no disclosures to inform, but let's look at the subtopics of my presentation today. Understanding cancer care disparities, what are cancer burdens, the key challenges in Malaysia, cancer care, multidisciplinary approach, how MDTs, multidisciplinary approach, are short form to MDTs, barrier to effective MDT implementation and addressing challenges moving forward, and I will summarize the whole. So let's talk on the first topic. So how do you define healthcare disparities? Basically, healthcare disparities are systemic differences in health outcomes and access to treatment driven by different socio-economic disparities, geographic, cultural, and other systemic factors. Okay, I've got a lot of numbers here, values in ringgit and all that, but this is probably old data, 2018, 2025, things have already gone up, I'm sure. Like, let's look at economic barriers as such in terms of mammogram costing, generally about 230 ringgit. I do not know how much Sunway Hospital charges, but you can find out. Okay. Mammogram in general, if you look at the data based on this paper here, equivalent to 4 to 7% monthly income for an individual. In the urban side, it may take about, income may be about 5,000 ringgit in general, lower in the rural areas. Screening uptake of mammogram. Mammogram, we all know what mammogram is. It's to look for breast cancer. In the rural areas, it may take about 8%, which is much lower than the urban areas. Geographic access and challenges. Basically, what I'm trying to say here, in certain areas, they may offer free mammograms, but they require patients to travel a long area. This may be more pertinent to the West Coast, the East Coast, or even in Sabah, Sarawak, that sort of area, and it may cost them to travel. Regional disparities, that only 6 to 8% of women in rural areas can be screened. Can you imagine that, when you can actually detect them more? Sarawak situations, very limited mammogram machines, forcing many to travel a long way just to have that mammogram done. How about looking at costs in terms of direct and indirect medical costs? I think we need to be aware. Now, the average cost per hospital, again, these are all numbers which are probably dated, but per hospital episode can be about 7,000 ringgit. Now, in terms of what they can have is, if you go to the hospital, surgery, chemotherapy, radiotherapy, hospital stays, medication, diagnostic tests, all these things are generally covered in our government hospitals, but in private, obviously, either you self-pay or you co-pay or you have your insurance to handle that. Indirect medical costs, you're looking at, let's look at it. How do you get to the hospital? You have to travel. If you don't have a place to stay, you have to, rent a room, rent a hotel room, all these things, meals, daily expenses, and if you have kids around, who is going to take care of the kids during that time that, you may need treatment, and loss of income during, when you have treatment, you will have loss of income. And all these things are not covered. Literacy in terms of health. What I'm trying to say is that not many patients are aware. Although I'm coding down to breast cancer, but I think it's a very common disease we should be aware of. But 23% of women reported doing self-breast examination regularly. Now, as an oncologist, we always advocate self-breast examination to detect any new lumps, and if you have a lump, see your doctor immediately. But only 23% of women know about this. 36% would have undergone clinical breast examination, meaning that a doctor will be doing it, whether it's a GP, whether it's a breast surgeon, will be doing a clinical breast examination. That means they don't show up to the breast clinics to have that. And only 22% would probably have received a mammogram. Cultural beliefs also plays a big role in our Asian community, in Malaysia, in Brunei, I'm sure it's the same thing, where 75% of women fear of the diagnosis of cancer. I think this is relevant to any individual. 70% worry about costs of treatment. 66% would fear losing a breast, which may be tied into identity, femininity, and marital concerns. Although in this day and age, we're always trying to conserve the breast. I think there's newer technology available, newer treatment available. So, but that fear of losing the breast is a big issue. Discomfort with male healthcare providers. I mean, I have women who say they'd rather not have a male oncologist. Nothing wrong with that. I can get you to see a female oncologist because you're not comfortable having a guy examining your breast, right? Preference and reliance on traditional remedies which delay clinical diagnosis. I mean, this is all the ubat kampung and all that. They may have steroids inside instead of having actual treatment, and by the time they show up, the disease has progressed. Cancer burden in Malaysia, a lot of numbers coming up. 2022, based on global trend in Malaysia, you can actually see this all online if you're interested. If you see 51,000 new cancer cases in general, I think this is more 2022, 31,000 deaths annually, about 142 people per 100,000 get cancer. The mortality is 86 per 100,000. Right? I've not compared, not showing you comparison. I'm just talking about what we have here. Top cancers in Malaysia, these are all the statistics and numbers that you can see here. I won't repeat them, you can read them. Breast cancer, colorectal, lung cancer are the common ones. There are many other cancers to think of. Top cancers in men, lung, colorectal, prostate cancers. Now this is something that should be aware of, the overall burden. In 2022 itself, there's about 51,000 new cases of of cancer in general. By 2023, there's a projection. They've already projected the data that it's probably going to go up to 67,000. In view that we are an aging, we are getting society is aging and all that. So regional income and ethnic disparities in cancer care plays also a role in terms of the cancer burden, in terms of rural areas where screening consistently lower in rural communities. Example, cervical cancers only picked up about 49%. If I remember right, I think the value in a more urban area may be about 50 to 60%. Of course, that's still not good enough. Rural areas are less likely to detect early breast cancer, early colorectal cancers, contributing limited awareness, fewer facilities, financial constraints. That's all that. Regional gaps in terms comparing east to Peninsular Malaysia. Although more cervical cancers are seen in Peninsular Malaysia, but does this mean that we are picking it up more in Peninsula because there's more awareness? So you do not know what is not picked up. HPV vaccination and screening coverages are low across both areas. HPV vaccination is quite known to reduce the risk of cervical cancers. I think we did used to have a program in Malaysia, but that has stopped. For some reason, I won't get into that. Sabah and Sarawak face greater access to challenge due to geographic barriers and fewer health facilities. I had a stint in Sarawak for a while, and you had patients coming in, some of them actually with cancer, and they don't have really good transport, and from their kampung they have to walk about 100 kilometers just to gain access to a boat, and that boat has to come all the way to, not to Kuching, but to an area where you have to find major transport to Kuching to get treatment. So what are the key challenges in cancer care in Malaysia? Again, nothing new. A lot of our patients come in with late stages. I would have to admit that in the government hospitals, we tend to see this a lot more often. Stage 3, stage 4. Breast, colon, lung cancer. Financial burden is one of the challenges when it comes to cancer treatment. High out-of-pocket cost. Patients may have to spend about 42% of their yearly income in cancer-related expenses. A public sector report, I think one of the reports here can have a read, is that, the report out-of-pocket costs can be about, 10,000 ringgit per year, excluding traveling, lodging, and other income losses. Insurance, we all talk about insurance. I think it's a hot topic for the past year in terms of insurance policies and all that. Things are getting more strenuous. Inflation is going up, and we used to depend on insurance to pay for all our treatment. Now we're going to things like co-payments, where you pay half of it, they can't pay for everything. So all go home and check your insurance policy, right? So other issues, other challenges that we face is referral delays. Basically, if there's patient has been clinically diagnosed that is potentially a cancer case, it may take a long time before the patient actually sees someone to have their treatment, their disease diagnosed. And a lot of times, it takes even a longer time just to reach the oncologist subsequently. Communication gap, no unified patient records, every specialist documents separately, increasing the inefficiencies. Specialist shortages and bureaucratic hurdles within public hospitals also drive a lot of issues, like doctors moving out to the private practice, and this can also burden the whole system. So urban and rural divide, again, same information, where specialist services like oncology, radiation. As an oncologist, I'll be talking about oncology, radiotherapy, pathology. We depend on them on diagnosis of cancer, which are mainly available in urban areas, Klang Valley, Penang. So it's all concentrated here. Rural areas rely on limited public facilities and leading to delayed or missed care. Long waits, especially in radiotherapy, outdated machine, limited numbers of machines, and shortage of trained biomedical engineers. These are engineers that will manage the radiotherapy machines and such. Systemic cultural barriers, delayed help seeking, many seeking, take over 6 months for first symptoms before they even seek help. Cultural, psychological barriers, low health literacy, fear of diagnosis, cancer stigma, preference of traditional remedies. So how does, now this is the main topic here, is how does multidisciplinary approach in cancer treatment matter? Now when you talk about multidisciplinary approach, we're talking about a group, not just one head, but multiple heads managing a patient. So what is a definition of multidisciplinary approach? Multidisciplinary team, or MDT, is a collaborative group of effort of specialists who jointly assess a patient together, ensuring the treatment is comprehensive, personalized, and what's important is evidence-based. So let us compare traditional model versus MDT model. Traditional model is what happens when you just see a doctor and he or she gives you a plan in terms of, the care is delivered, but the planning is, it's separate compared to a joint consensus where, everyone sees that patient and comes to a decision. You can see, look at care delivery, it's just working alone versus a team, decision making is, of course, if you're going to see one doctor after the other, it's going to be sequential rather than, so a surgeon may refer to another surgeon if necessary, so it's one after the other before finally you have that treatment. So there will be a lot of delays here. Documentation very commonly is fragmented. We don't get all the necessary information. We always have to keep relying on calling them, can I have this information, can I have that information? So the patient experience is inconsistent while it's more holistic when it comes to a multidisciplinary model. And of course, guideline adherence. A lot of times, as we all undergo training as specialists, we always look towards guidelines. And when it comes to an MDT model, then everyone is on the same page when it comes to managing the patient based on evidence. So who is in this team? You would ask me. Now I'm talking about cancer care. So the core team would be generally I have to put the surgeon up there. surgeons will be number one. Not so, because oncologists, we do get the referrals later because they all get screened first. You know, they will see a surgeon would diagnose, and they would probably send to the radiologist, the pathologist who do the, to read the biopsies and all that. But all in all, they all come together. When we have that meeting, we will discuss, okay, this is our patient, we've got all this information here, what do we do? So isn't that better at the end of the day? But of course, you've got extended allied professionals. A lot of times, in most centers, sometimes this may not be in that working group, and I think this is where we can improve. We've got physiotherapists, dietitians, pharmacists. These are not small jobs; these are big jobs. So these are palliative care specialists. When you talk about stage 4 cancers, these are people that come in and help the patients holistically. So how do MDTs improve the outcome? So they improve the outcome. Okay, based I found that there's actually data to show that there is survival benefits from MDTs. Meta-analysis shows about 40% reduction in mortality risk, and patients actually start treatment faster, almost 12 days earlier. And although 12 days seems like a short window period, but it's better than nothing. So we can actually get started on treatment, patients' treatment as soon as possible. Higher diagnostic and treatment accuracy. MDT discussion leads to changes in care plan. Okay, maybe a doctor that refers the patient to the MDT may say, okay, I've got this plan for the patient. We need to do this first compared to this. But when you actually go through the MDT, then you'll look at it holistically and say, okay, looking at this, we may not need to do this treatment first, we have to do that treatment first. What I'm trying to say is that even when you have, say, colon cancer or rectal cancer, not all patients are operated first. They would have chemotherapy first or radiation first before going in, So we all need to be aware of this. So that's why I say it can lead to discussion and changes in plans. Adherence to current guidelines and best clinical practice, very important. So of course, you would have better patient communication. If you tell the patient, I'm going to discuss your case with 10 other people, 10 other doctors, don't you think the patient will be happy? It's not just one doctor it's not about ego here, it's about patient, best care for the patient. So you discuss, and they will be very happy about this, knowing that, I've got Dr. A, Dr. B, Dr. C all looking after me. So it reduces the confusion, ensuring consistent messaging from all teams. Also, what's important here, there's educational value. MDT meetings is, of course, a lot of junior doctors in training will be there, so they will learn, okay, these are the best ways to manage the patient. So it's very good information there. And it promotes continuous learning through real-time and case-based. Barriers, we have, of course, barriers, problems with MDT, especially implementation in Malaysia, and I would say in most countries. Limited resources and manpower. Many regional hospitals lack oncologists, trained nurses, and MDT coordinators. Urban centers face high caseloads, limiting time for proper MDT discussions. I mean, I've sat in an MDT meeting, and at one point there'll be 20 cases to discuss, and you've got to discuss that in 1 hour, because everybody else got, after from 8 a.m. to 9 a.m., 1 hour to discuss 20 cases, and because everyone else got, other jobs to do. Geographic inequity, MDT is mostly based in Klang Valley, Penang areas, and selected private hospitals. Rural areas depend on irregular and unavailable virtual MDTs. These virtual MDTs, since the pandemic time, plays a big role, but it's not easy to be. Lack of standard protocols. There's no standard protocol on how MDTs function. Everybody's got their own style, and the differences in how MDTs meet, how decisions are made, and how cases are documented. Timing, scheduling, hard to coordinate between busy specialists. I've tried handling an MDT meeting. I said, okay, we've got to discuss this case. I call this fella, then this fella said yes, then that fella said no, and then the first fella said no again, and everyone changes their mind. So to come to this is also difficult. Virtual MDTs can help, but often slowed by tech issues. That can be a big problem. I've got colleagues my age who don't know how to use Zoom Meet and all that, and I have to teach. So I think I'm pretty good in technology. But But yeah, you know, it is a problem. It is a problem. Technology gaps again, stable internet, yeah. Electronic health record systems also are not easily accessible. Where, you know, cost of low digital literacy, staff resistance, face privacy and workflow challenges. I think privacy is still a big role. We just can't simply share things, you know, to everyone. You know, so we have to know that, you know, there's PDPA involved here, you know, as such. Nurses allied staff often are unrepresented. You know, we, as much as I do not. I mean, it's something that, you know, we do ignore. You know, nurses and other allied staff play an important role, as I mentioned. So we shouldn't ignore them because they're going to also look at the other aspects of the patient. So we should keep them in the loop. All right. So doctor-led meetings may limit through interviews. So the doctors are actually talking more. You know, you're not giving other, you know, other allied health to give their opinion. So, you know, the doctors take charge of the whole situation. So how do we address those challenges? We have this thing called the National Cancer Strategic Planning for Cancer Program, and also the what is this? The City Cancer Challenge, the CCAN. Okay, these are the you can see this is a cancer plan for cancer control, and also this is a global initiative to improve city level cancer care. These are all, you know, we are trying to get to improve where. They are trying to say that all oncology centers require to use an MDT approach, trying to make it as a guideline, yeah? MDTs must include treatment planning, pathology review, radiology input, tele-coordination, all these things we need to set it up. So this is something that we should, you know, strive to move forward to. Infrastructure and accreditation, we need to accreditate those centers that have MDTs, set clear standards to improve quality and radiology pathology services, support and upgrade to, you know, to electronic health records for easy access, quick, you know, so that, and you can document there and then, you know. So a lot of times when during an MDT, there will be a junior medical officer writing down the, you know, the case notes and all that, and then actually when you review, what did you write here, you know? You know, this is not what we discussed. So it's actually on the onus of the senior doctors to pay attention to what has been written in MDT findings. So a lot of times we don't do that. Standardization of protocols, use structured forms, checklists, aligned with national cancer guidelines. We have also national cancer guidelines around breast cancer, colorectal. Ensure consistent comprehensive care discussion, training your staff to look into it. Public and private collaboration, I think this is also important, not easy to be done, where the private center works with the government center to decanter out, reduce the workload of government hospitals. Of course, NGOs, industry support and awareness campaigns also play a big role. So anyway, this is my final slide. So what are our key takeaways? So cancer care disparities stem from, you know, the socio-economic inequalities, rural, urban, limited early detection, right? Late diagnosis is a common problem due to low awareness, high costs and fragmented care. MDTs improve the outcome through coordinated, patient-centered as well as evidence-based care. Barriers include shortage of staff, inconsistent protocols, infrastructure gaps, you know, must be addressed. So the national cancer strategies like, you know, NSP, CCP, and City Cancer Challenge can show ways to provide, you know, to scale the MDT to a bigger level, training, digital tools, you know, to improve, and also better collaboration to improve the whole idea of managing our cancer patients. So with that, I thank you for your time.